Hello everyone, my name is Chamnani Rungprai from Department of Orthopedics, Pramukutgao Hospital and College of Medicine, Bangkok, Thailand. Today, I would like to present a surgical demonstration of Achilles tendon rupture, a Giftbox technique. Here's my disclosure. I have no potential conflict related to the presenting video. For patients who have Achilles tendon rupture, usually present with suddenly sharp pain on the back of the heel, feel like someone kicked them from the back. Oftentimes, they're hearing a popping sound. When Achilles tendon rupture, they're unable to do heel lift or unable to walk. Recently, the American Academy of Orthopedic Surgeons published a guideline to help for diagnosis of acute Achilles tendon rupture. There are 4 criteria. First, clinical Thomson test positive. Second, presence of a palpable gap. Third, increased passive ankle dorsiflexion with gentle manipulation. And fourth, decreased ankle plantar flexion strength. The diagnosis of Achilles tendon rupture will be made when there are at least 2 out of 4 criteria are present. This video demonstrates a palpable gap on the defects of the rupture, compared to no defects on the normal tendons. Next video demonstrates positive Thomson squeeze test. The ankle cannot move, compared to normal movement of the ankle in negative Thomson squeeze test. And this video demonstrates increased passive ankle dorsiflexion with gentle manipulation on the right foot, and also decreased plantar flexion strength. At present, there still remains a controversy for the best treatment of acute Achilles tendon rupture between conservative versus surgical management. However, there are generally acceptable population for the surgery, including young patients, high-demand patients, and athletes. For the operative techniques, a modified crack-out stitch is the most commonly used technique. However, the flaw of this technique including less strength, suture not present on the repair side, and this can lead to increased stress and early failure. Recently, a Giftbox technique has been proposed and was proven by biomechanical study. This technique was 2 times stronger than a traditional cat-crown repair in cadaveric models. In addition, no suture knot is left between the repair side. The advantage of this knot outside the rupture side can decrease the stress of repair and prevent early failure. Surgical demonstration, a Giftbox technique. The patient will press in a prone position with the ankle at the edge of the bed. A thigh tourniquet will apply with an edge mark for the buttless field surgery. A midline incision is performed based on an angiosome theory for preventing wound complications. Carefully dissect the soft tissue, avoid injury to the sural nerve and lesser saphenous veins. In addition, keratinol should be preserved and should be repaired after the surgery. A rupture site can be identified. Oftentimes, if they present late, a scarring should be removed from the edges of the stump. After complete debridement, the gap should be evaluations, and tendon approximation should be checking before the repair. And number 2, non-absorbable suture is used to repair in a Giftbox with a modified crack-out techniques. A first stitch should start in an area of a good quality of the tendons, and the cross stitch should be approximately 8 to 10 mm from the lateral border of the tendons, and always perform a locking loops as shown on the videos, and always tightening the suture before begin with the second stitch. The next loop need to be 10 to 15 mm from the first loop, and always locking loop and tightening at the end. For the third loop, it depends on quality of the tendons. If the tendon have poor quality, we prefer the 3 loop over the 2 loop system. For the crossover stitch, unlike a original techniques, we prefer to go through the tendons to prevent the suture irritation on the posterior parts of the heel, and these techniques is shown in the videos. After the suture across to the other side, make sure that the suture is tightening before we begin with the first loop on the other side. And the suture should be performed with the same manner with the locking loop. And the interval between each loop should be between 10 to 15 millimeters. Another important point, each stitch shouldn't be on the same fiber to prevent a longitudinal split. Should be slightly overlapping, and each loop need to be approximately 10 to 15 millimeter, as I mentioned earlier, and always tightening before begin the next loop. And the final throw need to be exit at the middle half of the Achilles tendons, and stability can be checked. After finish the distal stump, we will start repair a proximal stump with the same manner. A number 2 non-absorbable suture we used to repair with the modified crack crown stitch. An Alice soft tissue forceps is used to pull the tendon down. And number 2 non-absorbable suture can be used to repair with the modified crack crown technique, similar to the distal stump. The first row need to be made sure exit at the good quality of the tendon, approximately 10 to 15 millimeter. And the second loop, the interval should be between 10 to 15 millimeter. And always perform with the locking loop and tightening at the end before begin with the third loop. And that is the same concept, similar to the distal stump. If you questionable about the quality of the Achilles tendons, I prefer to use the 3 locking loops instead of 2 locking loops. Again, always tightening before you perform a cross stitch. For a cross stitch in the proximal part, you cannot throw the needle in one round. You may need to divide the Achilles into 2 parts, and you begin to throw the needle from the lateral to the center. Again, from the center to the medial part, and the techniques is shown in the video, and locking the loop when you exit into the medial part. And the next loop should be 10 to 15 millimeter distal to the proximal loop, and the third loop with the same manner, and always tightening at the end. And the last throw of the suture should be insert 10 millimeter proximal to the stump and exit in the middle, and then the stability can be checked. The final suture is a sliding stitch. We use a free needle. The entry point need to be close to the core suture, and which usually go 2 rounds. The first round go about 15 millimeter, and the second round exit approximately 5 to 10 millimeter proximal to the most proximal cat-cow loop. And we do the same manner with the other half of the Achilles tendons. And make sure the sliding stitch not capture to the loop from the previous cat-cow stitches, so otherwise it cannot be slide. And again, exit 10 to 15 millimeter from the most proximal loop of proximal stump. The next step is perform a sliding stitch on the distal stump. We do the same manner. The entry point need to be close to the core suture, and do 2 rounds similar to the proximal stump, and make sure you exit approximately 10 to 15 millimeter distal to the distal loop of the modified cat-cow stitches. And we perform the same way on the lateral half of the Achilles tendons and exit at the same positions, carefully not to capture the cat-cow stitches. After complete a sliding stitch, we can close the gap by tying the suture both ends of the Achilles at the same time, and the assistant will hold the ankle in 20 degrees plantar flexions. Suture can be tied on one side of the stump. I usually prefer to tie distally because the tendon is stronger than the proximal part. And after finish, I will check the tensions, and I finally tie on the proximal part and to make sure that the tendon is not too tight or too loose. After finish, you can simply check with the Thompson squeeze test. For the prominence of the suture notch, I usually hide the notch inside the tendons, while do another suture stitch as shown in the videos, and you tie on the medial side of the tendon, which has more soft tissue to protect, and then you can cut the notch. And on the distal stump, you can do the same techniques, but I highly recommend to tie on the medial side rather than the lateral side because the notch can irritate with the sural nerve. So medial side is more safer and less soft tissue to protect the suture notch. And then cut the suture with a sharp knife. After repair, a Thompson squeeze test will be negative. In addition, we restore the strength of the plantar flexions. For the final step, the paratenon needs to be repaired in order to prevent the scarring and provide a blood supply to Achilles tendons. After complete paratenons and skin closure, an anterior blocking splint will apply and allow patient to perform plantar flexion as tolerated. A postoperative protocol anterior blocking splint will be applied for 2 weeks. At 2 weeks, stitches will be removed and the patient will switch to the CAM walking boot with early range of motions, and they will allow to progressive weight bearing in the boot with 3 pieces of heel wedge at 4 weeks post-operatively. In addition, strengthening exercise, proprioception, and balance training can be performed. Patient can do cycling and swimming at 6 weeks post-operatively, and they will remove a heel wedge, the first one at 6 weeks, the second one at 7 weeks, and the third one at 8 weeks from the surgery. Full weight bearing in the tennis shoe will be after 8 to 10 weeks from the surgery, and they can do walking exercise after they remove the boot. Walking will allow at 10 to 12 weeks, and running will allow approximately 12 weeks from the surgery, and they can return to sport between 4 to 6 months from the surgery. In conclusion, a Giftbox technique is a simple technique. A biomechanical study will demonstrate that the strength of the repair is at least 2 times stronger than a standard modified crack crown repair, and no suture notch is left inside the repair site, leading to decrease the stress on the repair site and prevent early rupture after the surgery. So thank you for your kind attention.